So good afternoon, and thank you for joining us for the first session of the 2022 Older Adults and Opioids webinar series hosted by the Finger Lakes Geriatric Education Center, a HRSA-funded geriatric workforce enhancement program at the University of Rochester, and our co-sponsor, the Western New York Rural Area Health Education Center, also a HRSA-funded education center. My name is Laura Robinson, and I am the program coordinator for the Finger Lakes Geriatric Education Center. My co-host and co-sponsor is Christine Chappell, the administrative coordinator at the Western New York Rural AHEC. We are very glad you could join us for our third year of hosting this series. We also welcome the interpreters for today's session, Kate Pedersen and Anthony Bizzaro. Thank you so much for being with us. And before we begin, we just have a few housekeeping items. There are two very important buttons on your Zoom toolbar. Please use the chat button to type hello and introduce yourself with a name, job title, agency, and location if you'd like. We have people from across the country and the world joining us today. So we'd like to welcome people from all across New York State, Oklahoma, Tennessee, Pennsylvania, and Sylvia in South Africa. Thank you so much for joining us here today. The other button that you need to know about is the Q&A button that will allow you to type in a question for the presenter. We ask that you use this button at any time during the presentation to ask a question so that the question does not get lost in the chat. We will leave time for questions at the end of the session. So for now, I want to go to the slides and tell you a little bit about our CME credits and social work credits. Here are our learning objectives for today. We do have to do these official disclosures to individuals that we have no relevant conflicts of interest for this presentation. None of our planning committee or our speaker today have any conflicts of interest. And if you are going to be claiming CME or social work credits, we will send you a link and some instructions following the webinar. And it's very important that you do list yourself in chat because we will be taking attendance throughout. So only folks that attend the entire session, especially social workers, will receive credit for this session. So we will send you an email after the session. Also, no commercial funding was used to support this webinar, only HRSA funding here today, which allows you to attend for free. So thanks for being here. So now I'm going to take my slides down and invite our presenter to please put up his slides while I do his introduction. So today, our featured speaker is Dr. Stewart Auyash. Dr. Stewart Auyash is Associate Professor of Public Health Policy in the School of Health Sciences and Human Performance at Ithaca College in Ithaca, New York. Dr. Auyash researches, teaches, and gives talks on public health policy and communication, including the war on drugs and the overdose epidemic, pandemic responses, and prevention policies. He teaches across a wide range of public health and communication subjects. These include critical U.S. health issues, health communication, international health and human rights, pandemic response policies, genocide, public health policy analysis, the war on drugs, health narratives, international scholarly conversations, health lobbying, and senior seminar on public health policy. Most recently at Ithaca College, he co-designed and co-taught Cholera to COVID, a history of public health. In spring 2022, Dr. Auyash will be teaching an honors course entitled The War on Drugs, From Opium to Opioids. So today's lecture, I think, is just going to be a snippet of the information if he's teaching a semester-long course on this topic. So we're very, very honored to have such a knowledgeable and influential scholar with us today. So now I will now turn the program over to Dr. Auyash.
Thank you, Laura. Thank you, Christine. I also want to thank Zach Griswold for recommending me to you. I also have to thank Ann Olin, whose name you gave me and who I spoke to learn a lot more about what was going on in Rochester. I also want to mention Elizabeth Bergman, who helped me get my language straight. Elizabeth, if you're out there, or Marianne, if you're out there, correct me if I'm wrong as we go along. I also want to dedicate my presentation to the elderly people in my life, including my parents, who are both in their mid-90s, and also in memory of my mother-in-law, who passed away last June at the age of 97. I've been fortunate to have the learning experience that it comes with living and being around people who are even older than I am by a significant amount. I like to start actually by taking a minute for all of us to pay our respects to the memory of those who have died of COVID. Hold on a second, I can't seem to be moving this. I have to use this. During the last couple of years, there have been 6 million deaths worldwide, 950,000 and counting in the United States, 1,500 in Monroe County, or more by this time. And also 86.3% of all deaths in New York State were people over 60. So I'd like to please take a moment of silence to remember them. Thank you very much. So here's what I'll do today. I'm going to talk briefly about the war on drugs. I say brief because as Laura mentioned, I teach a whole course on this. So talking about it for 20 or 30 minutes is brief for me. I will talk about how we ended up with our current overdose epidemic after that. I want to talk specifically about its impact on older people and their substance use, and answer the question, at least try to, about where we can go from here. But first, I have a question for you, and you can put your answer in the chat. My question is, what do you think is the most dangerous drug in the United States today? Oops. So I can't see the chat. Maybe Laura, you can give me some ideas about what people are responding, how people are responding.
Yes, so far we've got alcohol, Oxycontin, opiates, Valium, fentanyl, alcohol, tobacco.
Very good. Thank you. Somebody got it right. Without question, without doubt, still the number one public health problem is tobacco. It kills far more people than any other drug. Alcohol is a distant second, and then all the other drugs that were mentioned, all the other drugs, even though they're leading causes of death today, they're far down the list. And they're still important, of course. Losing 100,000 people a year from mostly unintentional overdoses is a serious problem. Thank you for answering that question. So my brief history will start by mentioning that we've had drugs, we've looked at drugs for years, and the Chinese have been using opium since the 7th century. There's even some argument that actually, based on the interpretation of Sumatran tablets or cave wall drawings, that people have been using opium for even longer, far, far longer than that. I'll talk a little bit about the opium wars. I'll talk about something you might remember from high school history class called the Whiskey Rebellion, and the temperance movement from the 1830s to the 1920s, the post-Civil War era, which some people claim is the first really overdose and opioid epidemic, and the wars on alcohol and marijuana before I get to the current situation. The opium wars were fought in the harbors of Hong Kong to start, the harbors of Shanghai to start. The British, of course, were bringing opium from South Asia and Central Asia to the Chinese in exchange for their tea and their silk and all the other wonderful things. And the Chinese at one point said, enough already, we don't want to trade opium anymore. And so, as you can see from the drawing or the painting on the left, they bombed the ships in the Shanghai harbor, and that started the first of 2 opium wars. The 2 gentlemen on the lower right are obviously smoking opium, and when I had the occasion to be in China and travel around in the mid-1980s, I actually saw people, especially in the rural areas, who actually were still smoking opium. Quickly moving on, let me just mention one more thing about this. In exchange for bombing the ships as a result of a real war, we know what real war is now, with bombs, etc., then the British end up taking away a couple of islands away and didn't give them back to the Chinese until the 1990s. That would be Hong Kong and Macau. In the US, we actually had a rebellion in the Western Pennsylvania when the moonshiners there wouldn't pay the whiskey tax. And General Washington, or at that time he was President Washington, sent off a crew there. Some people actually died during that battle. Now, as the country grew and as we began to enjoy ourselves, never before have we drank more alcohol than in the 1830s. There is a picture there on the left of Carrie Nation, who was famous for taking that axe and, as the cartoon shows in the bottom, hiding it in her petticoats and in her jackets and walking to the bar and smashing it to smithereens as best she could before she was grabbed and then arrested and then let out. The temperance movement went on for quite a while, and I'll come back to that when we talk about the war on alcohol. The post-Civil War era lended itself to what some people think was the first really opium epidemic. Part of it was brought to the US by Chinese immigrants who were working as on the railroads, on the farms. And it was the beginning of an era where we can link the war on various kinds of drugs to discrimination against certain kinds of people. In this case, of course, it was the Chinese, and then it became immigrants and African Americans later on, and even indigenous peoples. And that image of that cartoon actually is one of the kinder cartoons. There are some cartoons that are really horrible and just horribly racist, as you would imagine during that era. David Courtwright is a major historian with the war on drugs, talked about opiate addiction and cocaine use in the South during that era as well. And unlike what many people think, that Southern whites actually had the highest addiction rate of any regional racial group in the United States. And he also claimed outside of the Chinese, probably the largest rate of addiction anywhere in the world, possibly. And that's partly because the medics during the Civil War used opium as a way of treating their soldiers when they were in pain from injury during the Civil War, and they came away addicted. Black people in the South had a very relatively low rate of addiction, and when they did use drugs, which was rare, they did tend to use cocaine. And despite no evidence, Black people's use of cocaine was really related to what some people claimed in the headlines was a national crime wave. And it wasn't unusual to use that as an excuse for committing crimes such as lynching against Black men in particular. Here's another example of the use of cocaine during the Victorian era, when women were wearing corsets to try to slim as much as they possibly could. Cocaine was used as a quencher for one's hunger, and that enabled them to develop the thin shapes they needed to get into corsets. The picture on the top, the black and white picture, actually is a real picture taken in a ward of the Civil War, where people were given opium as a way to treat their illnesses and their pain. It was considered to be a wonder drug, cocaine. And yes, it is true. Cocaine was originally in Coca-Cola. That's where the Coca comes from, cola. And they voluntarily took out cocaine in the early 1900s. And you can guess what they replaced it with. And if you guessed caffeine, you'd be correct, which is still part of the ingredients in Coca-Cola. There was a time when all this stuff was legal. All of this was legal. And you might recognize the Bayer name there. Heroin could be purchased. Here is a pharmacist in New York City that was selling it. And there are other examples too. Laudanum was maybe more popular. It was mixed with opium, and aspirin was also mixed with heroin. I thought when I got this slide on the lower right that it was Rochester, New York, but no. And then I realized it was Rochester, Pennsylvania, but that was the closest I can get. I'm sure there were some druggists in Rochester that were also selling laudanum. It was perfectly legal to do so at the time. Here's one of my favorites. It's a mixture of alcohol. It's also the first image that I found that actually included cannabis too, and chloroform and morphine. I mean, just imagine what that might do. A hospice nurse, who's a friend of mine, actually said that might be one of the things they might even use. It's for someone at the end of life, but nothing quite like that. It wasn't just for adults either. They actually manufactured cocaine tooth drops. And in the 1880s, when this was made, 15 cents was kind of a lot of money. But still, if it soothed the toothache of the child, then probably was well worth it for adults to keep them quiet. It did other things too, but that's not been reported on as far as I can tell. That no children were addicted to cocaine. I couldn't find anything about that. So who's in control of all this? I mean, this was just widespread everywhere. Well, in 1906, the US government, partly as a result of the efforts and the book written by Upton Sinclair, that some of you might remember, called The Jungle, about the horrors of the meatpacking industry, they set up the Pure Food and Drug Act. The most important part of it that related to drugs was actually that drug labels had to say exactly what was in the label, what was in the bottle. And what became known as what was the Bureau of Chemistry was given the authority under the Pure Food and Drug Act to check drug labels. There were chemists there, and they would check the interior or the fluid in the bottle to see that it was actually what was supposed to be in it. Later on, that was renamed, of course, to the Food and Drug Administration. Now, this is probably the most important law that was passed in that part of the century regarding drugs. It is called the Harrison Act, and as you can see from the headlines, it was thought to be a statute that will wipe out drugs. However, there were many people using drugs, people who were addicted to drugs, people who were actually not even addicted, technically. They were being actually prescribed heroin. They were being prescribed cocaine by their doctors as a form of maintaining whatever pain they might have had, whatever issues they might have had. And so this caused them to become criminals overnight. They sued, the doctors actually helped with this lawsuits, and they actually were given a reprieve for a short period of time. Hence this stamp that was given by the United States. It's it was sent to a doctor, so that doctor had the authority to actually prescribe it. Probably the most famous part of the Harrison Act that you're familiar with, that we're all familiar with, is before the Harrison Act, pharmacists would not only sell drugs, they would also diagnose their patients. You just go to the pharmacist and say, I have a bad sore throat, or I have a sniffly nose, and they would say, take this. And doctors were also doing something on their own. They were selling drugs. So the pharmacists didn't like that the doctors were selling drugs, and the doctors didn't like that the pharmacists were diagnosing patients. So the Harrison Act set up the system we have today, which is where doctors prescribe. Maybe they'll give you some samples occasionally, but they won't sell anything. They rarely do anyway. And then the pharmacist actually fills the prescription. Now, going on to the next war, the war on alcohol. It happened because Americans wanted it. They were wanted for a number of reasons. One, women in particular felt that it was related to what we call today domestic abuse. It was also an effort on behalf of a number of people. And by the way, the picture on the right what you don't see is those two coppers on the right. They have their hands behind their backs. I'm sure they have a bottle of whiskey that was filled before they started dumping it down into the drain. Just my guess. But it was also a war on immigrants and the working class and African Americans. Working class men in particular would welcome the opportunity to go to saloons. Not only was there a women's Christian temperance union, there was also an anti-saloon league, which in some states actually was used by the Ku Klux Klan to then have an excuse to go after African Americans, Catholics, Jews, and anybody else they might have hated. That was particularly an issue in parts of Indiana. So the war on alcohol and the end of and the beginning of Prohibition really set up what was a lot of concern about what then became known as organized crime. However, we realized that that wasn't working, and Americans wanted it to be repealed. It's the only constitutional amendment that was ever repealed. One of the side effects of the Prohibition was that women, who rarely ever went to saloons before then, unless they were selling something, actually started going to saloons. They went to the Blind Pigs, they went to the speakeasies, and afterwards they began to drink. The other part of it, which I'll call later the Iron Law Prohibition, that was instead of selling as much beer as they did before Prohibition, they sold a lot more whiskey, because you could get a lot more money out of a barrel of whiskey than you could out of a barrel of beer. Now, the next drug war was also a war on another kind of immigrant, and these immigrants were coming mostly from Mexico. And the Mexicans brought their marijuana with them to relax at the end of the day, while the Americans were going to their saloons. Neither did they like that the same way they didn't like the Chinese, who were smoking opium after their long day of work as well. And as a result of that, the federal government, Hoover was the president at the time in 1930, and he hired someone named Harry Anslinger, who became a central figure in what we now think of even today as the war on drugs. He was part of the army of the was called the Bureau of Narcotics, and that was what he was the commissioner of. And you can see from the other headline that murder weed was being found everywhere. These other images might be familiar to you. For some of you who might be as old as I remember seeing Reefer Madness in college, but you also maybe didn't know that was Harry Anslinger who set up and paid Hollywood to make some of these films and organized these groups called the Interstate Narcotic Association. And anytime any evidence came up, including from some doctors that said marijuana isn't this way, it doesn't really kill people, people aren't dying from it, he quashed all of those kinds of reports. There was actually a law in 1937 called the Marijuana Tax Act that allowed marijuana to be sold, and all you had to do was buy a stamp for it. However, the government never sold any stamps, so it was de facto illegal, and of course it is still today a federal law that marijuana is illegal despite what the states are doing. But of course, let's jump way forward here to the 1960s. Marijuana becomes wholesome anymore, and it's not just for hippies. Those housewives, I remember when I was in college, my mother came home and then she said, people at this meeting were actually smoking, at this party, were actually smoking something. It didn't smell like cigarettes. She goes, do you know what that is, Stewart? And I said, I have no idea, Mother. I don't know what you're talking about. Thanks for asking me anyway. Now, Richard Nixon is credited with a lot of things. And one of them that he did was to start what we think of today as the modern drug war in 1971. Here he is sampling a little bit of the smell, at least maybe he thinks he is. And after he was impeached or almost impeached, I guess technically they formally never started the impeachment process, but he resigned and Gerald Ford became president and lost the next election to Jimmy Carter. And one of the things that Jimmy Carter was going to do, thanks to his friend Willie Nelson, is they were going to make the decriminalization of marijuana happen. That did not happen for a lot of detailed reasons that we can talk about later. So in 1980s, with Ronald Reagan as president, the plan was just to say, and fill in the blank, I think you know what it is, no. And it became Nancy Reagan's cause. The 1980s, however, also brought some tough things that actually lead up to the current situation with regard to opioids. They passed the Anti-Drug Abuse Act of 1986 that declared a lot of that cocaine and marijuana and heroin were all Schedule I drugs, meaning they are the ones that can never be prescribed and be allowed. Congress established much tougher sentences, and you can see there the differences between crack cocaine and powder cocaine were so stark as to be, totally an obvious attack on the African American community, which is more likely to use crack, and for which we're still recovering from that era. The Violent Crime Act of 1994 actually is what ended up being what today we think of as our mass incarceration problem. Michelle Anders' book, of course, called The New Jim Crow, details that in great detail about how that transformed the communities, African-American communities in particular, by leading to a point where more than half of the convicts or the people who were in jail in New York State were there for the violation of the state drug laws. The reforms became popular in the early 2000s, sorry. By 2014, Colorado passed the first state, ended the state prohibition on marijuana. And now you can see big ads in states where it's quite legal, and even Hollywood stars that are celebrating the consumption of marijuana. New York State has made it legal, and by this time next year, there'll probably be stores in our neighborhoods where people might be able to buy them. So what about the current opioid epidemic, and how did we get here? Well, first of all, there was a perfect storm of delivery, a delivery system. In 1995, the American Pain Society urged doctors to declare pain as a fifth vital sign, added to the normal things that doctors would ask about, or PAs or nurse practitioners: temperature, blood pressure, heart rate, breathing rate. Now they were going to ask you, do you have any pain? And maybe they give you the smiling face list, or they give you a 0 to 10 and pick your pain. And a lot of people had pain. We just ask ourselves, we feel in pain sometimes in ways that we don't even recognize until someone actually asks. The other thing that happened around that same time was OxyContin was produced and marketed by Purdue Pharma, claiming that it is non-addictive, and I'll show you the next slide in which they use that as proof. Those of you who may have watched the series on television called Dope Sick, or read the book, or many other books written about them, know the conspiracy that they were part of, and for which some of them and the company is paying for now. Also, some MDs were turning practices in prescription mills. They were just selling prescriptions. They would see 100 people a day. They charge them 25 or 50 bucks cash, and they write a prescription for OxyContin. I know that personal experience. My cousin, who I grew up with, who became a doctor, sold his prescription pad to an FBI agent and ended up in jail for 6 years. Also, around that same time in Mexico, a new form of heroin was made available that was cheap to produce in Mexico. And the Mexicans had a very smart, at least smart from their perspective, way of selling them as if they were just delivering pizzas, and were always under the radar, hard to track down. Now, I mentioned, how did we claim that there was no addiction to OxyContin? This was the research, and I put that term in quotes, that Purdue Pharma used. This is not research, as you know. This is a letter to the editor in the New England Journal of Medicine that's just described for 40,000 hospitalized medical patients. I'm happy to share more about this, but I'll leave it out there. So if you want to read it, you can. But anybody who had a simple research course in high school or college would be able to tell that this was not a very good form of research to make the outrageous claim that Oxycontin or other forms of opioids are not addictive. So we're using the term addiction. Let's just clarify a little bit. What is use and what is addiction? The use of a drug refers to the treatment under the supervision of a licensed provider. That came to a head in New York State under the iStop program passed in 2012, signed by Governor Cuomo, that basically started to track doctors who were prescribing legally opioids for pain medication. And unfortunately, the side effect that was nasty, because doctors were afraid they would get arrested if they prescribed too much. They didn't want anybody looking over their shoulder. And some people who were legitimately in need of opioids because of pain ended up going to the streets to buy their Oxycontin. And then eventually, when they couldn't find that or it became too expensive, they found other drugs that they would inject. Addiction, according to the National Institute of Health, is compulsive drug seeking and use. That's a short version. That would be people who end up stealing from their families, their friends, from anybody to get their drugs, and will do anything they can. It's compulsive seeking and use. Now, I'm going to show you a series of charts here to just describe the growth of it. This may not be a surprise for you people who are following this topic, but you can see from for the last 20 plus years, the numbers have dramatically increased. 2021 was even higher and approached 100,000. And the male and female ratios are roughly the same, males a little higher there. And just to show you this, compare the United States to other countries, we are far and away the largest consumers of opioids and have the most overdoses. That's only goes up to 2015, but it would continue on after that. There are types of opioids that are important to understand something about. The red line is commonly prescribed opioids. That would be the Oxycontins, Percodins, Vicodins, and other synthetic opioids is the one that's climbing the most. The most common one today is fentanyl, but there are actually lots of other derivatives and other kinds of things related to fentanyl. Fentanyl itself is about 100 times more powerful than heroin. There's something called carfentanil, might be as much as 1,000 times more powerful than heroin. And so even just a small piece of that powder could actually end up harming somebody if they were unaware of what's in their package. There are actually fentanyl strips that are sold on places like Amazon that people can get to test their drugs. Now, this breaks down the drugs a little bit more carefully, but I want to point out that the big blue line that goes up dramatically, of course, is the synthetic drugs, primarily fentanyl, they say. Now, I want to point out, however, that if you actually looked at the details regarding overdose deaths, that most of those people are actually multiple drug users. It's unusual to find just fentanyl in someone when an autopsy is conducted. It's often mixed with meth, might be mixed with alcohol. That's a common ingredient. Mixing oxy or any kind of heroin with alcohol is a very dangerous combination, and any other combination. So the vast majority of people who overdose actually have multiple drugs in their systems, even though it's considered to be an opioid death by most. It's really hard to find, I have to say, and if you can help me, I'd appreciate it. Hard to find data that was really specific to the aging population or to elderly or older people. And here it shows not that there is an increase from 1999 to 2015 of overdoses among people over 65, but not nearly as high as the rate of death in the other groups. But if you look in the middle, you see the 55 to 64-year-old age group is climbing as fast as some of the other younger groups. The overdose deaths were thought of for a while to be related to central part of the United States, mostly young white people. Some of you may have heard about the deaths of despair. Actually, in the last 4 years, it has affected the African-American community far greater than we had previously thought. Here's one that does break it down by age groups. And if you add, you can add up the numbers from 55 and higher or 65 and higher to see that there were a large percentage of people over the age of 65 that were actually using, this is as of 2019, and also experiencing overdoses. Now, almost all overdoses are unintentional. Some may be considered to be self-inflicted suicides, but most of them are considered to be accidental. One piece of data that I found, this is in the Queens Borough of New York, compared men and women, and you could see that that age group still was affected. On the left, men in particular, over the age of 61, almost 11% of the overdose deaths were attributed to that age group. Now I have a slide. I'm not going to show you this, but it's actually a website, and rather than going back and forth between the web and here, I can just tell you that the Kaiser Family Foundation, and I could put this information in the chat later, also in my bibliography that I'll share at the end of the slideshow, has some age-specific pieces of information that show that the increases over the years of the overdose deaths among people who are over the age of 55. Now, what we know about people over 65 is that 9% actually take it regularly for pain and prescriptions. About 20% of people over 65 and older actually fill an opioid prescription per year. A survey was conducted by the Council on Aging of 200 community-based organizations said that 70% of the people who work there said they're spending more time on opioid-related problems than ever before, and that they increased their efforts, meaning 20% actually reported needing to have a special circumstance, a special person who is going to be responsible for that. So why has the opioid-related issues increased among older adults? Lots of reasons. The researchers claimed that it was partly because they're taking care of their grandchildren. People don't know how tough that can be. Lack of access or understanding of the alternatives, such as how even to get transportation to go see a doctor or even get medically assisted treatment. The challenges of getting refills and the restrictions that iStop placed in New York, for example, and the difficulties of managing the side effects of opioid use, which are many, by the way. And older adults had fewer options for pain, and doctors were still too cautious. What are some of the side effects? Well, older bodies, I've read, really obtain more fat, and fat, the opioids actually go into the fat and absorb more of the drug. Kidneys don't filter out drugs as effectively, and opioids interact with other drugs and are more likely to cause side effects. Some of them, as you can see here, are really debilitating over a period of time. Constipation being a really serious one that can end up someone in the emergency room. Now, there are some local issues. Alcohol appears to be #1 drug in Monroe County, as it is in many other places. Tobacco aside, because people in the social work field won't see as many people or won't notice as many people perhaps smoking tobacco. There are more outpatient services that are needed for care, such as medically assisted treatments, which we'll talk about in just a bit. Barriers to paying for care. Medicare does not pay for Suboxone, which is a treatment that's used for medically assisted treatment. Medicaid does, and also covers methadone. Older people who use opioids often use with other drugs, as I mentioned previously. And there are more staff that are needed to meet these serious challenges. So what would a sensible drug policy look like? How do we treat prescription and over-the-counter drugs? I forgot to tell you at the introduction that I happen to be a drug user. I am taking a prescription drug known, I can't remember the name of it, but it's a blood pressure drug. And that blood pressure drug is so important to me that if I stop taking it, if they said you can't use blood pressure drugs anymore, I'd have to go on the street to buy it. So even though we at one point in time, we were able to prescribe prescription drugs to people who needed opium or opioids for pain, we don't do that anymore. In order to be able to do something more about this as a society, we have to be non-judgmental and decrease the stigma about the use of drugs. Why have we decided to ban certain drugs? It's a question we need to ask more deeply and more broadly. Oops, sorry. One of the things we need also, in addition to non-judgmental or destigmatization, is to regulate drugs, make them affordable and safe. That's what they're doing to marijuana now in New York State. Some of you may think of that as something that's going to be uncontrolled, but actually New York State, compared to some other states anyway, is going to be if they follow through on the law, it'll be pretty highly regulated and affordable and safe. Now, I mentioned the IR law prohibition. This came from Richard Cowan, who said whenever drugs we ban or prohibit, or for which we reduce access, will be replaced by drugs that are stronger and more dangerous to other users. As law enforcement becomes more intense, the potency of prohibited substances becomes more intense. That's what we're seeing now. So what can be done? Well, I'm using an Ithaca example because I know it the best. Happens to be a friend of mine, Dr. Justine Waldman, who opened up a clinic using the acronym REACH. She was tired as an emergency room physician of seeing people continuously come into the emergency room who were addicted to various kinds of drugs, and she wanted to help them. She learned more about it. Nothing was available, and she set it up a medically assisted treatment clinic in Ithaca that provides buprenorphine and methadone, and also looks at people and does not test them, does not grill them, does not judge them, and allows them to be in a safe place. They're also offering primary care to people. When people come in with a need for a winter coat, they help them find a winter coat. They even have veterinarians come in on occasion to treat the animals that the people might bring with them to the clinic. Now, some places like Canada have opened up what I call opioid service centers that goes by many different names. Two of these recently opened up in New York City, where people come to bring their own drugs and use in a safe environment where if they overdose, they can be saved. I visited 3 of these in Toronto just a few years, actually just before the pandemic. There is a lower overdosing from attending and going to these service centers, which of course have to work in coinciding with the drug enforcement police within that area. They provide all the safe things that people need to deal with drugs safely. Here is a pop-up drug site that I took a picture of in Toronto, a place called Moss Park. Here is one of the first ones in North America that was legal. It's a place called Insight, which is in Vancouver. Since 2003, they had 3.6 million visits, and they saved almost 6,500 people. In 2019 alone, they had over 1,000 overdose interventions and helped save people's lives. What I'm talking about here is harm reduction. Some of you might remember from the days of HIV early on when HIV was being transferred and transmitted between people who are injection drug users. And some renegade activists set up a system where they would deliver the needles that were clean to those users so they wouldn't pass around HIV. Because what is the greater harm? Someone getting HIV, especially at that time when it was really untreatable and deadly, and whether people were using drugs seemed to be a minor circumstance around that particular topic. Here are some of the books that I use that I've listed. I use these in my class, but also list them in my bibliography that's here at the end. And I have a long bibliography here that you can look at your leisure, but that is where I will end and say thank you very much for allowing me to present this information to you. I look forward and will be happy to answering any questions that you might have. Thanks.
Thank you so much, Stewart. That was amazing and thorough and a lot of information. I just put a note in the chat for folks. If you have questions, we have plenty of time left for questions. Use the Q&A feature and we can read them to Stewart, or you can read them to yourself and answer them. I wrote down a couple notes on as you were talking. So tobacco being the biggest threat to public health. That's amazing after all these years that we have known how dangerous it is that continues. And does tobacco lead to more opium or opiate use in later life? Was there any evidence of that?
I think there's a myth around gateway drugs.
Okay.
Some people think, well, if you're going to smoke marijuana, the next thing is hash, the next thing is cocaine, there really is no, there's a myth around gateway drugs. Based on that trajectory, you could argue that milk is a gateway drug. What they do find, however, that in states that have legalized marijuana, the overdose death rate has remained steady or even has gone down, and less than in other states in which marijuana is not legal. So it might very well be the advent of marijuana, and we don't know why yet, because it's really too new to really get some of that research to be refined, that it might be related in some way as a sort of maybe not a substitute for opioid use, but as a deterrent in some small way among some groups.
Okay, thank you. And so that was a good pause to allow folks to put some questions in the Q&A. Are you able, Stewart, are you able to open the Q&A and just go through, or would you like me to read them?
I saw Lynn Wilson asked, how do we encourage this shift and change to harm reduction? Thank you for that question. We have to all be harm reductionists. That's one way to start, by telling you that. And what I would suggest, rather than going into great detail here, is to go to the website of the Drug Policy Alliance. It's drugpolicy.org. They all put that in the chat. Maybe can't find my cursor here, but it's drugpolicy.org. And you will be able to find lots of resources there about harm reduction, and even give you some articles to share and some people to contact. Or you can contact me after the talk, and I'd be happy to also talk to you more about that in greater detail. I see another question comes from Marcus. Are more opium drug service centers going to be opened up in more areas to save you from more lives? Thank you, Marcus. He's a student in my class who always asks good questions. Marcus, not yet. We're still, that New York City was hard. It was hard to get that started, really hard to get that started. And we wanted to open up one in Ithaca too. I do know for a fact that there are underground injection sites that are available, that are around, even pop-up sites that happen, but those are illegal, and people risk their lives and their livelihoods actually by working in them. But it might be a while, and maybe the research that we get out of New York City and those two centers will help open it up for other people. Marianne Erickson, good to see you, Marianne. As the baby boomers become elders, do you think drug use among elders will increase? Well, it's interesting from a standpoint of what we know about the marijuana usage now. When marijuana became legal in Colorado and California and Washington to start, there were concerns that teenagers are going to be increasing their drug use, increasing their marijuana use. Well, as it turned out, their marijuana use stayed about the same. It was the boomers who were going to the marijuana stores and buying the pot. So it might very well be that, yes, there might be more drug use. If you're talking about marijuana, at least that's something I do know about regarding the data, that it appears as if they may be using it more. People who are professionals, professors, doctors who want to get pot don't want to do it illegally because they don't want to lose their livelihood, and now can go and buy it legally. And so it might very well be that that increases among that population. Elizabeth, good to see you too, and thanks for your help. How do we respond to family members of older adults who resist their older loved ones' use of opioids for pain management for fear of addiction? The challenge that I've actually had experience with was to find someone who my older relative trusted. In that particular case, it was a doctor. It was a doctor that I didn't particularly like because I thought the doctor didn't know a lot about treating older people. But I would use the doctor because I had permission to speak to the doctor to suggest that they might want to try a small dose of marijuana, a small dose of some opioid of their choice to provide some treatment. So it might very well be the doctor or anyone that they really might trust who's in the medical care field that might be the best person to work with. At least I understood you're correct and right. I hope so. If not, ask again. Hello, Mariana. In your opinion, what explains the racial disparities in drug policing? Well, I can answer that in a simple version by saying, well, it's racism, but it's more than just any form of racism. It's actually in a form of systematic and even structural racism that's been institutionalized by our drug laws. Look at the penalties that were passed in the 1990s. And I must say, the penalties were passed by the Democrats and Republicans on Black Congress members, white Congress members. Everyone was really in favor and wanted to look like they were hard on drugs. And they regret that. Some people regretted their vote on that. So I think that what we're going to be seeing here is a continuation of this. The good news in New York State about the marijuana legalization is that in other states, if you have a felony record, you weren't allowed to open up a marijuana. You couldn't get a marijuana license. But in New York State, because so many people are in jail for violation of the drug laws, especially peddling drugs, that they're going to be allowed to actually open up a store, even if they have a felony record. So there are some, I wouldn't call it quite a reparation, but it would be something along those lines. And so it would take a while for us to get over this. And I don't have any really short solutions to that, but good question. Thank you. M. Barnum, is there evidence of a correlation between car accidents and cannabis nowadays? The reason I ask is I am seeing signage saying do not drive while high. Absolutely don't have that data. It's really hard to get that data for a couple of reasons. One is marijuana stays in your system for a long time. And so someone might get high 3 days ago and might drive a car and get stopped. And the other part is, how do you test for somebody? And we have breathalyzer tests that you can test immediately at the scene of the arrest or the stoppage of someone who's speeding, but we don't have that test available for marijuana yet. And even if we did, the person might be able to claim, I don't have it in my car, doesn't smell like pot, go look on me, search me. I smoked 3 days ago, I admit it, but I'm not high now. So it's really hard it's gonna be really hard to enforce those laws unless we get a particular test that can be an immediate result, provide an immediate result, like breathalyzers.
All right. That was a lot of questions. Still have time for a few more if folks have any questions. Just a reminder, we will be sending out an evaluation survey. Also, when you close out of Zoom, an evaluation survey will pop up. I will put that link in the chat for you. We do value your feedback always, and we do use your ideas to plan our next sessions, and we will be planning next year's session in the coming months. So I will just leave the Q&A open for a few more minutes. Folks have any last questions? Otherwise, we can give you back a couple extra minutes in your day.
I'll add while you're thinking about any other questions that in my course that I'm teaching now on the war on drugs, many of the students, so if we're up to the war on alcohol. It took us 7 weeks to get through the war on alcohol. And now we're going to be starting to read Chasing the Screen by Johann Hari, which is really about our current situation. And there are 3 people involved with that. One is Billie Holiday, one is Harry Anslinger, and the other is, what's his name? Arnold Rothstein, part of the organized crime group, and a leader of the organized crime group. And they form the basis for that story. But it really is a very interesting story. If you wanted to look at one book that was going to be able to summarize what it's like for a police officer, for a teenage drug dealer, or for someone as famous as Billie Holiday was, and the argument that the author makes is that basically Harry Anslinger killed Billie Holiday. You'll see the dramatic effects of the war on drugs related to race and also gender, and also its really ultimate failure. There was a time when Ithaca College had a DC center, and I would teach a 1-credit course there on a Thursday night, Friday, and Saturday, rather than being stuck in a room on Friday all day. And I taught a course on the war on drugs. And I brought in people from the government who actually were enforcing the war on drugs. And then we went on a field trip on Friday afternoons to the DEA museum. They actually have a little museum in there, a little museum. And it was just an absolute propaganda about the war on drugs, how great it's been. Even after 9/11, this really, really got me angry to the point of writing a letter. They had remnants of the World Trade Centers in the museum. And I said to the agent there, why is that here? That had nothing to do with the war on drugs. Oh, well, you don't really know that. It could have been related to somebody who's one of those bombers. And it really was an exploitation, I think, of the whole 9/11 event, just for the purposes of them trying to scare more people into dealing with the issue of drugs.
One of the things that I've appreciated about your presentation today is that you directly tie in the systemic history of oppression of people of color in this country to the laws we've created and to this war on drugs. That's really just a war on people of color. So thank you for highlighting that and not trying to brush it aside or cover it up. It's very much appreciated. So with that, I see no more questions. I want to thank you, Stewart, so much for sharing your expertise with us today. This was a phenomenal history of our country and the war on drugs. So again, thank you, Stewart. Thank you.
Thank you. Thank you, everyone. Thank you for attending.
And thank you everyone for attending. So again, please take a few minutes to fill out our feedback survey on this session and any ideas you have for future sessions. We hope you will join us next month on Thursday, April 14th. We have Amy Board and Benjamin Oliveri from the CDC coming to talk about opioids in the disability community. So again, thank you everyone. Have a wonderful rest of your day and we will see you next month.
Laura?